Hi, my name's Dale Finucane, and I'm a member of the expert panel on health promotion and interventions targeting the mental health area of depression. Depression affects approximately 20% of adults either directly or indirectly in their lifetime, where twice as many women are diagnosed with the disease compared with men, and it tends to be skewed towards youth and middle-aged adults. Another alarming statistic, in terms of geographic location, those living in remote or rural areas are also more likely to be affected by the disease than those living in city or inner city areas. Depression is associated with an increased exposure to a number of things. Firstly, health risk factors, greater rates of disability, poorer physical health, and higher rates of death from any cause, even including suicide. Some of the statistics around the disease: depression is the leading cause of disability worldwide, and by the year 2030, the World Health Organization predicts that depression will account for the highest level of disability, and that's accorded any physical or mental disorder in the world. On a global scale, it affects approximately 5 to 10% of individuals, and is the third most common reason for consultation in primary care. There are a number of dangerous behaviours and outcomes associated with the disease. Drug and alcohol use, a negative effect that it has on relationships. It can cause problems at work and make it difficult to overcome serious illnesses. And the number one dangerous behaviour or outcome related to depression is suicide. And that can be either harming yourself and also harming other people as well. In terms of morbidity, disability and mortality in depression, suicide accounts for approximately 0.9% of all deaths. Depression is the most important risk factor for suicide, with about 21% of patients with recurrent depressive disorders attempting suicide. Approximately 40% of people do not seek help for depression, and less than 50% of those actually get the proper treatment that they need to have. So why the need for health promotion? The World Health Organization states that health promotion and preventative health approaches help to achieve overall well-being, decreased burden of disease and injury. It helps to address health inequalities, for example, in populations, the Indigenous disparity between them and white Australians. In terms of geographic location, as I mentioned previously, living in remote and rural areas compared with those in inner city areas, and also the gender disparity. Although women are more likely to be diagnosed with the disease than men, men are more likely to commit suicide, which is also a very alarming statistic. Further on why the need for health promotions, enhanced economic productivity, and the decreased economic burden on healthcare systems. So the less the government has to spend for the disease. A number of health promotion objectives: equity, and that's among populations, as I just mentioned. I guess the disparity between those in geographic locations, populations, and geographic locations. Improved population outcomes, supporting empowerment, sustainability and promoting community engagement. The health promotion action areas. The Ottawa Charter outlines what health promotion is about. And it's about building a number of things: building healthy public policy, creating supportive environments, strengthening community action, developing personal skills and reorienting health service. So in essence, what this is about is giving individuals the ability to make informed decisions about their health and empowering them to do so. So in terms of the expert panel, the purpose is to evaluate health promotion interventions in the area of mental health, of depression, and provide possible solutions and hypothesise reasons for the effective or ineffectiveness of particular interventions, and analyse its strengths and weaknesses. So the first intervention or initiative that's going to be discussed is the Secondary Schools Research Initiative. This initiative is aimed at preventing and reducing the number of adolescents suffering from depression and to help those that are already suffering with it. The study was completed in 2007 and the initiative ran from 2003 to 2005. It was a government funded organisation that cost $5.2 million. And the initiative ran across 50 schools from 3 states, Victoria, South Australia and Queensland, with 5,000 students engaged in the program and 3,000 staff members. So of the 50 schools, 25% actually completed the intervention, while 25 of those acted as a control group. And approximately 4% of adolescents suffer from depression, which is a very, very alarming statistic, and very few actually seek help or assistance to overcome it. That's very important because obviously this research initiative is based around adolescents. So there were four parts to the intervention. Firstly, a curriculum intervention, where 10 45-minute sessions were ran for one term, which was aimed at problem solving and social skills, resilient thinking and coping. The second part was about building supportive environments, so improving social interactions at school and in all settings, in all environments. The third part of the intervention was building pathways for care and education, so access to support and services both in the school and in the community, and having better relationships. And finally, community forums where students were given information to identify problems both for themselves and for their peers, and in the community forums, discussions around reducing the stigma related to the disease and breaking it down. So in essence, the intervention was about teaching skills to build resilience and increasing their protective factors and making young people less vulnerable to depression. Some of the major objectives of the initiative were about improving sense of connection to the school, improving pathways for young people to seek further help or further education, evaluating success of intended change, for example, improving emotional well-being and mental health, changing social and individual risk factors that the intervention targets, for example, relationships and social exclusion, and the change in level of depressive symptoms and level of risk and protective factors. It was about developing skills of self-worth, so strengthening, highlighting adolescents' strengths, skills and abilities, and to empower them. The sense of belonging, so making sure that they feel valued and accepted, and making sure that they feel connected to a group. And also control, coping with challenges, and helping them to deal with issues and being resilient. Finding a sense of purpose, so finding meaning in their lives, and increasing their sense of future, so acting purposefully and positively, and also the sense of humour, so seeing the lighter side of situations. In evaluating this initiative from a health professional's perspective, the biggest need for health promotion interventions from this perspective is that education that the issue does exist. Something can always be done. It's not a process. There is no quick fix. For example, it's not simply identifying they are sad. They know that their behaviour is challenging. They need to be made aware that there are avenues for them to seek help, and educate them to see a psychologist to help them change the result and establish some new behaviours. From the health professional's point of view, the intervention was on a too large a scale It needs to be more personal, and also in an environment that they feel they can trust. They may not feel this relationship with the school teacher, and also engaging with adolescents in this program may be difficult from a teacher's point of view. And also training teachers to implement the correct procedures may also be difficult and timely. And also only staff rated assessments showed improvements in the students, where in the conclusion of the study it found that there were actually no improvements through the initiative. And also, the study also highlights that a universal preventative measure was not successful. In evaluating the initiative from a target population point of view, they need to know how to change their behaviours, not what to change. It needs to be simple, and they're more likely to engage if it's a less daunting environment. Obviously, bringing up issues in front of a number of other adolescents, children are less likely to engage with that. Also, from the position of the target population, it was not very engaging. The teachers are simply delivering information, and students are made to complete it, so therefore it can be disengaging because it's a mandatory part of their schooling. And finally, they must be comfortable with the person who is delivering the information, making sure that they are fully qualified, someone who they can trust, as they might try and hide from the content also. The fact that there was nothing between for 10 days, it only ran for 10 days for the term for the year, so this age demographic learn by repetition, therefore there is nothing to build on. The groups need to be smaller, one-on-one, to have more benefit, and be in a less judgmental environment and feel safer. In evaluating from the policymaker perspective, large school trials are ineffective because of the teacher inexperience, and the expense to free teacher time for training and the government funds that are required to do so is unsuccessful. And as I just mentioned, the delivery system was also unsuccessful. A universal whole school approach is never going to be able to engage all of the adolescents. Also, in terms of the school having to change policies around behaviour management, decision-making processes to align with interventions is also difficult. And the fact that it was only a brief intervention, and there's limited acknowledgement of day-to-day environments for adolescents, so areas outside of their schooling were not particularly discussed. And the study also acknowledged that the lack of change in statistics over the 3-year follow-up was evident in the study. So in concluding and analysing this intervention, a previous study conducted by Payton in 2008 found a universal whole school approach was also unsuccessful, and Sawyer et al. 2010 states that smaller groups or individual sessions work best for adolescents dealing with depressive issues. So more planning and funding over a longer period of time to train teachers needs to be implemented. And for looking into the future, a change in the learning environment is needed, as it can be intimidating to address the problems in group environments in front of other peers, and no one's going to speak up. The interventions needed to be more regular. As I said, they only ran 10 sessions over the course of the term, and adolescents learn best through their repetition. The second initiative that will be discussed is the efficacy of peer support interventions for depression. The aim of this study was to compare peer support methods to usual care, so psychotherapy, to reduce depressive symptoms. And its objective was to reduce the impact of stresses and increase sharing of health and self-management information and provide positive role models. In this initiative, 869 participants completed it, and 301 acted as a random control to test the efficiency of peer support. The study also highlights a relapse in the use of medication for dealing with depressive issues, more than 50% in the first year, so this highlights a need for these additional services. So the intervention for depression is about bringing together non-professionals with similar stresses for mutual support and an experienced peer-to-novice peer delivery. And peer support services were either in groups, in pairs, in person, over the phone or on the internet. And 4 to 12 sessions will run weekly, and comparing this with the previous study, this is obviously more effective. So the key findings of the initiative was that peer support methods proved more effective in reducing depressive symptoms than usual care. And evaluating it from the health professional perspective, Gilbody et al. 2006 supports the notion that groups need to be small and supported by experienced individuals for reasons of comfort, and also that it's hard to have a blanket cover statement to see the preferences of whether people prefer groups one-on-one, over the phone or over the internet. So this caters to all individuals, and it's beneficial for other health concerns such as if people are also dealing with alcohol or substance abuse disorders or violent behaviours also. For the future, larger randomised controlled trials are needed to represent a greater population and groups. For example, populations such as the Indigenous, dealing with gender disparities. I think a further research can be done around these different populations. And also further research can be conducted to decide the best method of delivery, whether that be in pairs, over the internet, face-to-face, one-on-ones. In considering this from a policymaker's point of view, is there a significant burden? Discussing the effectiveness of the intervention, the cost, and the most cost-effective way. So we've discovered that yes, there is a significant burden, as 20% of people as 20% of individuals suffer with the disease. It is an effective alternative from a cost point of view, and the fact that and its scalability, and also its availability and affordability to individuals. The continued nature of the intervention is also advantageous when comparing it with the previous intervention, as this intervention is ongoing. There's no set time frame, and the fact that it's run across 4 to 12 sessions per week is also beneficial. The target population evaluation, the nature of the environment is trusting, it's in small groups, and it's personalised to the individuals. It is people talking to people with similar problems and similar stresses that they have in their lives. And they need to ensure that peer support leader has the capability and the knowledge to deal with the issues that people are dealing with. And unlike the school study, the content is more engaging and relevant to the individual. In concluding this study, a study found by Rush et al. 2006 found that peer support and cognitive behavioural therapy, psychotherapy, had similar outcomes. However, this peer review, peer support is more cost effective than psychotherapy, and it is effective from all perspectives. Target population from a cost, availability and scalability perspective, policy makers for cost and the burden of costs on the government, and also for health professionals. Any future research that needs to be conducted, you're trialling a number of settings and environments, for example, trialling in primary care or in schools. And it is effective when sessions are more regularly run compared with the previous study where only 10 per term were completed. And the fact that minimal government funding is required highlights the fact that this is a successful intervention. In conclusion, peer support extends to community organisations and society, reduces use of government and mental health resources. There's a clear policy for evaluating competencies of the session leader stated within the initiative, and people are able to develop their listening skills, relationships, helping to set goals and deal with emergencies, and it's all confidential. And the fact that it's self-care and deals with conflict resolution is also beneficial. And any issues with peer relapse is also very minimal, as they model the behaviour and are also very resilient. This concludes the presentation. Thank you very much.